Okay, so before you answer last questions, I have a question saying from Sinan. What's meant by 33 to 34 plus 6 over 7? Mean 30 weeks, 7 mean weeks, 33 weeks to 33 4 weeks mean 33 to less than 35 weeks.
Yes.
33 to 34 plus 6 over 7 mean 33 to less than 35 weeks. 7 indicate 24 indicate day, 7 indicate week, 12 indicate months, like the year, and 13 indicate month. That's usually how I apprehend. And Nasra Ismail said, I can't hear. I don't know what to do with you. Probably you're too late to ask these questions because you are not activating your mic.
Okay.
Okay, what's your question?
Dr. Yahya, thank you very much for your comprehensive lecture. We are commonly consider preterm baby with apnea. The first thinking in our mind that it may be due to gastroesophageal reflux. Is it a true gastroesophageal reflux in a preterm baby leading to apnea, or contraventional?
Yes, gastroesophageal reflux. Feeding itself might cause some respiratory problem because, as you know, there is suckling, and then swallowing, and there is breathing. So the baby should coordinate between these three, what we call it deglutition, and most of babies cannot. Now, gastroesophageal reflux may be a contribution factor, but I won't say never ever it's the first factors. No, it's not the first factors, because even if it's present, it's not serious problem. So if you have a premature baby, I would say it's an apnea of prematurity. If it's not apnea of prematurity, the first thing I would think of is infection. And then I would think about high CO2, hypoxia. I would think of hypoglycemia. I would think of environment, hypothermia. I would think of metabolic problem. And then I would think of gastroesophageal reflux, because as you know, sepsis is a very serious problem. Or if the baby is still term, if the baby is more than 37 weeks, I will never think of gastroesophageal reflux. I would say it's almost always 99.9 in a term baby is a pathology. So you need to think about seizure, about infection, about stroke, about neonatal encephalopathy, about metabolic problem. And gastroesophageal reflux, I don't know what to do, but what you will do, you want to give PPI, it will not work. What you want to do, you thicken the meal, it will never not work. You make positioning of the baby, you can divide the feeding, the volume. You did feeding, you don't, is not important, but you need to know to find the pathology. Yeah, go ahead.
Yes, true. What about the management? We are usually using tactile stimulation sometimes. To start with tactile stimulation and the oxygen flow. Usually,
you're mixing up between treatment and acute intervention. So tactile stimulation is an intervention for one event. It's not a treatment of apnea. So tactile stimulation is a treatment of pause or one apneic report. So when you have apnea by the nurse, can do tactile stimulation. If you have more, you can start CPAP. If you more, you might need to ventilate. If not severe, you can give loading dose of caffeine if the baby is not already on prophylactic caffeine.
Yes. And another question, last one. We are to differentiate between apnea due to seizure or apnea due to central cause in prematurity. due to seizure, we are usually using the cardiac record. If it is tachycardia, it is due to seizure more than to be due to central. Is it true, or we are to consider other thinking?
Now, the most common of apnea of in premature baby is apnea of prematurity. Now, seizures is always there. Seizure have many other factors. You have abnormal movement. You have stirring. You can have the cause of the seizure. How to differentiate? I don't think ECG, because somebody is typing me EEG. I don't think EEG will differentiate seizure. I think it's
Not
okay.
the ECG. I mean that if it is tachycardia, if there is high heart rate, it is more with seizure than to be with central apnea.
Well,
Like this.
I don't think that is incorrect because usually the heart rate of babies is high. They have biphasic response, hyperventilation, hypoventilation, hypoxia sometimes can cause tachycardia. I won't depend on the heart rate in diagnosing apnea versus seizure. Apnea is very clear. If you have more than 20-second pause, if you have less than 20-second pause with brady and decide, this is apnea. Now, is it apnea of prematurity or it's apnea due to pathology, including seizure? Then this is your clinical judgment. I mean, if there is any abnormal movement, is there is a risk factor, is there is any other symptoms? Usually when you have seizure, your activity change, you will find is your child usually is hypoactive. Also your history, your saturation level, your periodicity. There are many things that you can assess. Now, you can do EEG in a premature baby, but I doubt that somebody can interpret, including a very astute neurologist or pediatric neurology. Even if epileptogenic, pediatric epileptogenic epileptic person, it would be very hard for him or her to interpret EEG of a premature baby. I don't think EEG in a premature baby will help. It can help in asphyxia. It can help in diagnosing brain death. It can help because most of the seizures of newborn babies are secondary when you treat the cause. And that's another clue. It's not apnea of prematurity. You have a cause, sepsis, or electrolyte imbalance, or hypoglycemia, or hypocalcemia, or hypomagnesemia, or structural IVH, or structural problem. Mostly you will find, I personally never find a difficulty to differentiate. I don't know the setting. Most of the nurses can pick it up. I think it's clinical.
Okay, thank you very much. Thank you.
Okay, the question is, when we connect baby to mechanical ventilation, even nasal CPAP, I don't know what does that mean. Is it safely to stop caffeine? Why you stop caffeine? The baby is on mechanical ventilation. And CPAP, why you want to stop caffeine? I don't understand. Why you stop it? Whether it's safe or not safe, why you stop it? Remember that most of apnea of premature baby is central. So you're ventilating the baby, that does not mean the apnea is not there. And if you're ventilating the baby and baby is still apneic, you need to increase the setting. So giving the caffeine, preventing central apnea on a mechanical ventilation, that will help you to go to lower setting and then less damaging to the lung. And if you're on CPAP, why you want to stop? Try to stop the CPAP. You don't stop caffeine unless the baby is 33 weeks, but sometimes in persistent apnea, you need to go to up to 34 weeks. If you need 43 weeks, if you need more than 43 weeks, then probably you need a sleep study, as we discussed. Preteens. What preteens mean? Extreme preteens. Extreme preteen. Yes, of course. I've told you. All the babies less than 28 weeks, the consensus now from Canadian Neonatal Network, you start babies on prophylactic caffeine. I usually start loading 10 of caffeine straight per kg. I start like if the baby is less than 1500, or if the baby, and then I start maintenance 2.5 milligram per kg of caffeine. And the reason for that is sometimes I need to give more loading. So after 2 days, if there is no response or I still have apnea, I give another mini load of 5 milligram per kg, and then I pump the caffeine dose to 5. And then after a few days, I might need to pump it to 6 or 7 and 8. And each time I increase the maintenance, I give another loading. So yes, any babies less than 28 weeks, you need to start prophylactic caffeine. Because even if you need ventilated, as I told you, the apnea is central, not most, like 50%, like not 50, 40% are central and 50% are mixed. Only about 11% are obstructed. So you end up with, if you ventilate a baby and you give no caffeine and still there is central apnea, that means the baby with time will have desaturation and increase CO2, because that's what consequences of apnea. And that means you will escalate your ventilation. And there's decreased incidence of PDA, and there is the shortness of duration of ventilation and shortness the duration to need CPAP. And side effects are very minimal, very wide therapeutic range. The only problem with caffeine is the cost. It's expensive drug, more than thiophanate. So the answer in extreme preterm, any babies less than 28 weeks, yes, you need to give caffeine. Any more questions? No questions? Oh, there's one. You have 2 questions, Ibrahim. First, what is the various route of giving caffeine to preterm infant? Now it's an IV, you give it peripheral, you can give it central. And when your baby is 50% feed, so if your TFI is 120, let's say, well, in preterm baby, you reach 150. So let's say on day 2 weeks, you are giving TFI, total fluid of 150 per kg, and 75% of that is oral. I would switch to oral caffeine. But remember, when you give oral caffeine, there is a little bit of feeding intolerance with caffeine, because sometimes it causes some bowel ischemia. Not called ischemia, but decreased bowel perfusion. There is concern always. So yeah, when I would give it IV in less than 28 weeks, I would give it oral in more than 28 weeks. And then I switch it from IV to oral when I am 50% feed. The second question, can we try caffeine plus CPAP before mechanical ventilation? Of course. Caffeine, you should start it with 20 minutes of life. And CPAP, you should start whenever you need CPAP. And you continue caffeine and CPAP. And you escalate your CPAP until you reach 12 or 14 or 13. Never more than 15, and then you intubate. And when you intubate, you continue caffeine. You don't stop the caffeine. I know in Iraq is everything different. Use aminophylline, I don't know why. Aminophylline should never be used in... I should never use aminophylline. You always should use thiophanate. And it's better to use caffeine. Okay, I'm done. Thank you very much, and have a good day.
Thank you.